Let's go ahead and get started. Can you see my screen? There were like 20 some people signed up, so I'm not sure what happened. Plus I had to go in and back out. So people may join back in a little bit if I ended up cutting them off. So with that, let's go ahead and get started. Today, our topic is to talk a little bit about people who need help paying for home care services. And it's part of our advanced care planning series. So to start off with, basically, we're going to look at what is home care. Hopefully, most everyone has some sense
I'm going to go sit on the porch. I got in.
Okay.
Yeah, I'm also trying to do that.
So home care is basically personalized support services that allow someone to stay in their own home. If you need or want or use home care, you're usually using or asking for or getting support with things like personal care, companionship, homemaking, medication reminders, pet care, pet walking, help watering the plants, general things, if you will, around the house. And either around the house or helping you personally to continue to live independently. Usually people who provide this home care are trained so that it can be individually tailored. There are basically three ways that we pay for home care. One is private pay, two is Medicaid, and three is Medicare. To be honest with you, we're going to spend most of our day and time today talking about how we pay for home care via Medicaid. Before we go there, though, we're going to look at how do we decide, or how does someone decide that we need help with home care? And there are two things that we look at. One is the activities of daily living, and the other is the instrumental activities of daily living. And the sort of industry definition for activities of daily living is that we need help with things like bathing, dressing, incontinence, eating, mobility, and transferring. The instrumental activities of daily living are things that are kind of outside of us. So this is needing help with medication management or housework, preparing meals, somebody to help you pay your bills, somebody to drive you someplace you're no longer driving, maybe communication, things like answering the telephone, writing letters, making shopping lists, anything of that nature. And sometimes it's the result of cognitive deficits that we experience that cause us to need that help. So how do we measure ADLs and IADLs? So, and why do we measure them? Well, we measure them to make sure that the person who is receiving those services actually needs them. Because we always want people to be as independent as possible. But sometimes as we age, our ability to either be physically independent or cognitively independent, those things are declining. So the functional or clinical assessment helps us to really look at what are our current health status, what are our current health needs, and then to try to figure out potentially what we might need in the future. Now, understand that an assessment is not necessarily a one-time only. Are the slides sharing now? Okay, sorry about that. So the functional assessment, basically what happens is we are looking at what are the tasks that either require help with another person or some type of technology or adaptive equipment. So as you see in the picture here, the lady needs help walking, so she has a walker. Potential safety hazards, such as falls, slipping on the stairs, carpets that may be randomly sitting around, transitioning from a chair to a standing position oftentimes causes people a lot of problems. Help with medication administration or medication management. Do we always get all the pills in the right pill minder? Do we remember to take them? Do we forget to have them filled? So that's kind of what medication administration or reminders looks at. Cooking and dietary supports, laundry, shopping for groceries and other necessities, and then transportation for medical appointments, grocery shopping, and picking up prescriptions. Now, when we pay for home care privately, we can pay however we want, and we don't have to be quite as specific on this functional assessment because we're using our money to pay for this. If we are asking for the federal government or the state to pay for this through either Medicare or Medicaid, there are a lot more guardrails, if you will, put into place to make sure that services are medically necessary. So the primary way that we get home care paid for is what the health department calls a Class B home care agency. Sometimes these are often in the lingo of the world referred to as non-skilled home care agencies. So you will hear things like, we provide non-skilled services, or we provide skilled services. The skilled services are Medicare approved. The non-skilled are either private pay or they can be paid for by Medicaid. The Class B home care agencies are licensed by the state of Colorado. Their average cost is between $30 and $40 per hour. Usually they have a 3 to 4 hour minimum, and you have lots of flexibility because you're paying for this yourself on the services that you can get. Now, one of the major complaints that I frequently get is people need help with transportation. And unfortunately, many of the Class B home care agencies will not provide transportation because of the liability involved. So they will go do your grocery shopping for you. They will go pick up a prescription for you at the pharmacy. But if you need somebody to escort you to the doctor's office, then often these non-skilled home care agencies are not able to help. Now, sometimes I suggest, and sometimes it's kind of costly, but sometimes I suggest, well, have the non-skilled worker go with you in, say, an Uber or a taxi, because then they can accompany you getting in and out of the car. They can get you to the right floor and those kinds of things. It can be pretty pricey because sometimes you end up being at the doctor's office for 4 or 5 hours from the time you leave your home until you get back. But it is a way to get there privately. Now, how do you know who these Class B agencies are? How to find them? One of the ways that you can do that is we have at our website at senioranswers.org a housing and home care locator. And if you go to our homepage and click on this blue button, you will get a list of those agencies. Now you have to search for it because it goes in alphabetical order, but there's a little button there that says service, and you click on that, and it will then take you, you scroll down, and you'll get to home care. So we call that filtering. The kind of information that it will provide you is it will provide you for the location of the actual where the home care agency is located in the state of Colorado. It is a statewide agency or a statewide directory. So regardless of where you live, you can search on that. It will give you the areas served of the home care agency. So if they're like located in Denver, but they go all the way from Fort Collins to Castle Rock or whatever. It will tell you the types of services. So whether they're providing home care, whether they're providing companionship, whether they provide in-home services, whether they provide overnight care, whether they do deep cleaning, all of that will be noted. It will also tell you what types of payment options there are. So whether or not they take Medicaid, whether they take Medicare, or whether they take private pay. There is a link to the Colorado Department of Public Health for the latest survey results. So you can go out and see what types of things that the agency is doing well, where they have been cited by the health department for things that did not meet regulation. And then it's very, very searchable, as I said, by location, payment type, and services. So for the next number of minutes, and this is going to be the majority of the presentation, we're going to focus on Medicaid because I'm going to take you through the process of actually being able to apply. So Medicaid home care has 5 different types of programs. There's the elderly, blind, and disabled. There is the chronically mentally ill or CMI waiver, the brain injury waiver, community-directed attendance support care or CDOS, and in-home support services. And again, these are, once you apply for Medicaid and are approved, the process for actually receiving them and qualifying is the same. So the first thing we're going to do is a functional assessment. And that assessment is done by an agency we call the single entry point. And the single entry points are assigned, they contract with Medicaid or healthcare policy and financing. And then the case management agency or the single entry point, you have to work with that agency that is assigned to your county. And I'll make these slides available. So if you aren't getting all of this down, don't worry about it. You can review them later. Now, to qualify for Medicaid, there are 2 things that you have to qualify for. You have to qualify functionally and you have to qualify financially. So on the functional side, you have to qualify physically or you have to qualify mentally and psychologically, needing some type of supervision or behavior management. And you'll have to qualify financially. So let's take a look at the functional assessment. And the way that this is organized, and I started out, if you will remember, saying there were 6 basic things in the functional assessment that home care agencies look at. So under bathing, they look at, are you able to shower, bathe, or take sponge baths for the purpose of maintaining adequate hygiene? And then based on that definition, the case manager will score you a 0 through a 3. So 0 is independent. You can do it for yourself. A 1 is that you need some type of oversight or reminding. 3 is that you actually need some kind of hands-on or standby assistance. And then 3 is that you totally need somebody to help you. Now the 0 through 3 scoring criteria are for each one of these different types of activities of daily living. So this one looks at dressing. And again, they define dressing as the ability to dress and undress yourself. Can you put on a prosthesis? Can you put on your own support hose? Can you use other assistive devices? Do you have the fine motor skills to zip and zip your zippers and close buttons? Can you put on your winter coat or your summer coat? Can you get, the zippers on the back of your dress or your blouse do not constitute a functional deficit. And the reason for that being that you can buy dresses that button in the front. So again, we're going to use that same scoring criteria. 0, you can do it yourself. 1, you can dress or undress yourself with some limited assistance. 2, you need help walking through it, but you can do it for yourself. And then they have this thing called a reasonable amount of time. And what I have had different people tell me over the years is that they consider that if it takes you 20 to 30 minutes to get your clothes on, that's an unreasonable amount of time. And then the third one, if you get a 3, is that somebody has to do it for you. Whoops. The next one is toileting. This is where you are able to use the toilet, a commode, a bedpan, or a urinal. And you can get in and out of the toilet or on and off the toilet. You can clean yourself. You can change your soiled underwear if you need to. You could manage an ostomy or a catheter, and you can get your clothing adjusted. So again, 0, you can do it independently. 2, you need some assistance. 3, you need physical assistance with standby. You need some help. You need a bowel and bladder training program. You need help with a catheter or your ostomy. And you're really unable to kind of keep yourself clean. And then the last one is you're not able to use the toilet. The person or the caregiver determines, or you determine, that you need observation, help cleaning yourself, changing your garments, and you basically become total care. Mobility. This is the ability to move between locations in your environment, in your home or your apartment, as well as going outside. You get scored without regard to use of equipment other than the use of a prosthesis. So if you are using a walker, they do not consider you independent in mobility. So 0, you can do it by yourself. 2, you're mobile in your home, but you need some assistance. This might be being in your home using a cane or a walker. 2 is you can't really go outside your home or between 2 locations. You can't go down to get the mail. You need queuing, you need standby assistance. So 2 is basically you're going to need some help. And then 3 is you can't move at all. So transferring, this is the ability to move between bed surfaces. So this is, or surfaces. So this is getting in and out of bed, to and from a wheelchair, walker. Can you stand up on your own? Can you do this with or without devices? So I have one lady, for example, who is very careful about how she positions her walker. So with the use of a side rail on her bed and her walker, she can get in and out alone. Again, they score you with the ability without regard to use of equipment. So when you're using equipment, then you're going to score a 2 or a 3, depending on what kind of equipment you use. And then they're looking at, can you do it alone? Can you do it with assistance? Or do you need some kind of help? The last one then is eating. And this is the ability to eat and drink using routine or adaptive devices and utensils. So this is the ability to cut, chew, or swallow your own food. If you're fed via a feeding tube or intravenously, they want you to check 0, because if you can do it yourself, or 1, 2, or 3 if you need somebody to help you if you have a feeding tube. What I will tell you is that very rarely are older adults able to get any scores above a 1 on this particular criteria, and that is because most of us can feed ourselves. We don't have difficulty with that. But this is a scoring that is used for children, it's used for disabled individuals, people with a lot of handicaps, as well as for older adults. So that's eating. Then the next thing is supervision. And remember those first 6 things, because we'll come back to those in a moment. So supervision, behavioral supervision is, are you able to basically do things safely and refrain from unsafe actions or interactions? This is the ability or the inability or unwillingness to basically be safe. This is things like oftentimes also more like children not really knowing boundaries, or sometimes we see people who have mental health issues who don't have a clue about how to keep themselves safe because they're hitting each other, they're hitting things on their way, they might be knocking their head against a wall. So they're really doing inappropriate behavior that is either injuring themselves or property. They may require redirection with some intervention, or they may be at a higher level where they put others and property at risk. And this happens even with verbal redirection. They're really unable to interrupt themselves or stop these inappropriate behaviors. And then the last one is when they are causing physical harm to themselves or others. And my suggestion is, if someone is causing physical harm to self or others, they probably need to be in a higher level of care than home care. And then the last one is supervision related to memory. And again, this is a person's inability to acquire and use information, the inability to reason properly, to do problem solving, to be able to tell somebody what you need, or to communicate. So again, if your memory is intact, you don't get any points. If you can make most decisions in a familiar situation, you get a 1. If you require constant and ongoing reminding and assistance with planning and regular supervision, you can get a 2. And if you need help with all of those things, most of the time, this is when you're really looking at memory impairment. So now what we do is we make the determination whether or not you need care. So in those first 6, bathing, dressing, transferring, incontinence, you have to get 2 2s. So as we were going through scoring those, if you got 2 2s, you're eligible for Medicaid. If you get 1 2 on the supervision, either for behavior or for memory impairment, then you would qualify. Now, that's what this is telling us. So then you either meet the level of care, and then is there professional medical information supporting the need for home and community-based services. So this is basically, I just cut and pasted, if you will, the sections out of the application. So if the case manager, the single entry point agency, has determined that you need care, then the next decision is, where is it provided and by who? So is it home care? Is it hospice, mental health? Is it in a nursing home? And then the rest of this basically gets filled out once they determine who the provider is going to be. Now, this is if you're new to services. If you're getting ongoing services, then they just go ahead and fill this out with the existing information that you have. This just tells, again, programmatically which type of group you're in. Most of us are in the frail elderly, 65 plus. There are some people who are in brain injury or who have developmental disabilities or psychiatric services. And then this tells where it's delivered. Again, usually you're approved for home and community-based services, and then we qualify for one of those different 5 types. People can be approved for nursing care, or they can be approved for PACE, which is the program for all-inclusive care for the elderly. In the Denver area, we know them as InnovAge. Also, they do some care up in Fort Collins and in Pueblo. In Colorado Springs, it's Rocky Mountain Human Services, I believe, who provides it. In Grand Junction, Delta and Montrose, it's Volunteers of America. In the Boulder Weld area, it's True Pace. So there's different companies around the state that provide that. So then we're going to look at financial eligibility. And to be eligible for Medicaid long-term care, again, this is institutional care or nursing home care, the Medicaid waivers, or regular Medicaid, aged, blind, or disabled. We don't really care about the regular Medicaid. We make reference to that. And what we're mostly concerned about here is the Medicaid waivers, the home and community-based services. Now, the biggest difficulty that we have with this determination is that the way the feds look at this is that they require that you be sick enough to qualify for nursing home care, but that you are able to be taken care of in a non-medical environment, either in your own home or in an assisted living that accepts Medicaid. And that's what this column is telling us here. So if you're a single person, your income cannot be less than about $3,000 a month, and you can only have $2,000 in income. If you're a married couple, you can have almost $6,000 in income, but $3,000 in assets. And if you are married with one spouse applying, again, the $3,000 rule applies on income, but on assets, you as the applicant can only have $2,000 in your name, but the well spouse or the non-applicant can keep about $162,600 of your assets. And this middle group is basically the one that we are most concerned about for this particular presentation. So what counts as income? Employment, alimony, pension, Social Security, disability, railroad, Social Security, SSI, IRAs, stocks, anything Social Security. The one exception basically is veterans, aids, and attendance. If your amount is above the basic VA pension, then that does not count as income and can be used either if you're in a private pay situation or with Medicaid, and you would get both. So income for a couple, basically one spouse applies, then basically the applicant's income is counted, the non-applicant is not. So this is what we look at then for how does the spouse who is well or the non-applicant, how does that get treated, and how do we look at their income? So the non-applicant spouse, this is the person staying at home, or the person who is not applying for Medicaid, can qualify for a minimum monthly maintenance needs allowance, or what we sometimes call an MMMNA. And this is the maximum amount of income that you would require to avoid being really poor or impoverished. So this number changes every year from July 1 to June 30th. In Colorado in 2026, you can keep $2,643. If your income is below that, then the income from your spouse who is going on Medicaid can be transferred to you to bring you up to that amount. So let's just say that your Social Security was $1,800 and your spouse's Social Security is $4,000. So your spouses, they can transfer approximately $750 of your spouse's income to you, and then your spouse can keep the $2,643, and they would be eligible. Both of you would be able to get, you would get the MMNA, you would get the spousal protection, and then your spouse would be eligible. A non-applicant spouse in Colorado can also qualify for a little additional money with the standard shelter of about $800. And this can come out of your spouse's income as well. And that is really good because that brings your income, if there is enough available, up to approximately $4,000 per month, and still allows the spouse as the applicant to be eligible for Medicaid. Now, again, this rule for the MMNA does not apply if you are only on regular Medicaid and you're not trying to stay in your own home, or you're not using it for income. Now let's look a little bit at assets. So what are countable assets and what are non-countable assets, or exempt or non-exempt resources? So basically, countable assets include cash, stocks, bonds, investments, crypto, bank accounts, savings accounts, checking accounts, money markets, anything that's pretty much in cash, including IRAs and 401ks. Okay. Things that are non-countable basically are personal belongings, household furniture, one car, an irrevocable burial trust or burial policy that is less than $1,500. If it's more than that, then you have to make sure that it's irrevocable. And usually your home is exempt. Now there's a couple of caveats on your home as well. So how does Medicaid look at your assets? So they say that regardless of how your assets are titled, they are owned by you jointly. So even if my husband has $500,000 in his name only, and I only have $300,000 in my name, Medicaid would say we have a total of $800,000. There is something called the Community Spousal Resource Allocation, or the CSRA, that allows the couples to protect a certain amount of their assets. So again, the non-applicant spouse has to go into title of that property. So the example I just gave you of my husband having $500,000 and me having $300,000, we would be way over the CSRA because we could only jointly keep $162,600. Okay, so we would have to do what's called a spend down. So our $800,000, we would have to use by 640,000 approximately of that before we would be eligible for Medicaid. Now, if I only had $200,000, then I would only have to spend down about $38,000 to be eligible for Medicaid. Now, here is where we get into trouble a lot of times. So, using my example of my husband and I with $800,000. So sometimes people say, well, I'll just give my money to my kids, or I'll give it to charity or whatever. Well, Medicaid has what they call a 60-month look-back period, or 5 years. So if I had $800,000 and I gave it away last week, and I decided this week to apply for Medicaid, that $800,000 is basically subject to the $600,000 or 60-month look-back period. And I can get credit of approximately $4,000, no, it's a little bit more. I think it's closer to about $6,000 or $7,000 per month. So I would, of my $800,000. So let's just say it's credit for $6,000 a month. So I could get credit for $36,000 a year. So basically, after 5 years, I still would not meet the 5-year look-back period. But after 5 years, they can't penalize me if I gave away more than I was allowed to. Now, this look-back period applies to both of us. Now, we can transfer assets as a couple between us. So if everything is titled in joint tenancy and we decide to title it, which I would recommend, all in the community spouse or the non-applicant spouse, we can transfer that without the 60-month look-back period. Now, violations are basically penalized, as I said. Now, the other thing that gets people in trouble, especially people who go see attorneys who do not understand Medicaid law, but who understand tax codes. So under the tax code, there's a gift tax, which says that I could, in 2026, give away $19,000 per recipient. So if I had 3 kids and I had my $300,000 and my husband has, together we have $300,000, I can give each kid $19,000. And that puts me up to 3 times 19 is $61,000. My husband can also give away to each of those 3 kids another $19,000. So now we're up to $120,000. I have 4 grandkids. I can give each one of those an additional $19,000. And pretty soon I don't have $300,000 left because I've given it to all my kids and grandkids, right? Well, that works for tax purposes. But for Medicaid's purposes, I have now triggered this 60-month look-back period, and I'm going to be eligible for giving away my $300,000 until I have served that look-back period. It probably on $300,000 wouldn't be the full 6 months, 60 months, but it would be pretty significant. Now, there are some exceptions to Medicaid and for assets. One of those is your home is automatically exempt if you as the spouse live in it, if you have a child under 21, or someone permanently blind or a disabled child of any age lives in it. So if you had a disabled child who was age 40 living with you, the house would be exempt if you went on Medicaid. If you do not meet any of those exemptions, then there is something called a home equity interest limit of $1.1 million. And this home equity is the value of your home minus any outstanding debt against it. So what that means is that if you have an $800,000 home, it's going to be under that $1.1 million. And it will be this exempt as set up here if you are a couple. If you live in a $2 million house and you are the applicant's spouse, then you do not meet this 1.13 million and your house is not necessarily exempt. So what basically happens is that Medicaid can put a lien against it for up to the $1.1 million. Now, if neither the applicant or the above mentioned family live in the home, then one way to exempt it is to create what we call an intent to return. And the intent to return is sometimes it's unspoken, but it's better to do it in writing. And this should be done via a letter that says that you as the individual, even though you are now in an assisted living or a nursing home, intend to return home. Now, if you're only doing this for home care and you have not left your home, then you don't need to do this intent to return. But if you are in your own home, you've met the home care requirements, and now unfortunately you're going to have to go live in an assisted living or a nursing home, then you may want to create this intent to return home that basically says, I want to die in my own house. Now, a lot of Medicaid attorneys use this intent to return home. They'll get it notarized and they put it in your file and they'll file it with Medicaid. The single entry point has the ability, according to the Medicaid rules, to evaluate after 6 months if you had to leave your home and go to an assisted living or a nursing home, if returning home is really feasible. And if they determine that it is not feasible, then they can basically negate this intent to return home and say that your home now becomes a countable asset. And although we're talking mostly about Medicaid and home care, once your home becomes a countable asset, then 2 things can happen. Either the state can put a lien on it, or you can sell it and then use the proceeds of the home to basically pay for assisted living or nursing home care. Now, as I said, that's not necessarily the topic of our discussion this morning, but I want to make you aware of it just in case you find yourself in that situation. So if the state does deny or the single entry point, I should say, deny your intent to return home, under Medicaid, there is always the opportunity to file an appeal. And if you feel strongly or your family feels strongly that you will be able to return home at some point in time to die or to live there with different type of home care or whatever, you can appeal it. I suggest that you consider getting an elder law attorney to help you with that, just because they are more skilled and they have the ability to do that. The state, though, if your home is determined to be a non-exempt asset, or they deny your intent to return home, they can file a lien. And a lien that the state files is often known as estate recovery. This lien is very similar to a loan or a lien that you would put on your house if you borrow money. So in effect, you're borrowing money from the state of Colorado against your house, and that program is known as the Estate Recovery Program. What happens then is that the home might be the last remaining asset, because most of the time you yourself, not your spouse, but you yourself have spent all of your funds, and you're down to $2,000 because that's what's gotten you eligible for Medicaid. Then the house really becomes the last asset you have. When the state files a estate recovery, then basically they are in first position on the lien to be satisfied. So after the taxes get paid, if there are any taxes due, then the state gets paid under the estate recovery, which then they give you clear title. And then if there is any money left in the value of your home, then that is distributed very much like by your will or your personal representative, or however that is handled in your estate. Now, sometimes people ask me whether they should sell the home and use the assets to pay for home care, or whether they should let the state put a lien on the house. Having a lien is not the end of the world, okay? Because, and it's a gamble. So if you think you're going to use less Medicaid money than the value of your house. So let's say your house is worth $1 million. And let's say you're using $10,000 a month worth of Medicaid money. So the state puts a lien year one on your house for $120,000. Next year they put on another 120. So now we're looking at 240,000. And then you pass away. So now, yeah, you owe the state 240,000, but you still have then $800,000 basically to use and distribute. So it's really sort of an estate planning kind of decision that you have to make. There are 5 different types of Medicaid waivers. There's the elderly, blind, and disabled. This is the one we talked about, where you have to have the nursing home level of care. You get to stay in your own home or in assisted living. There's the chronically mentally ill waiver. This is when you have a mental health diagnosis for chronic mental illness, such as schizophrenia or something like that. Brain injury is when you have had either a brain injury from birth, or you've been in a really bad car accident, you've had a really bad stroke. The other two, the Community Attendant Support Services, or CDAS, this is the one where Medicaid allows you to hire someone of your choice to provide care for you. You are responsible for paying them, for providing the training and determining what their hours they will work. And there's a third party that handles the payroll. The in-home support services is very similar to that. And there the caregiver is employed by a participating agent, and then they're assigned to you to provide care to you. So it's usually a person you want, but you don't want the hassle of training and supervision and payroll and all of that. So then the agency does that for you and pays the caregiver. And now we'll switch for a couple of minutes to Medicare. Medicare home care, basically you need intermittent care. Usually you have to be in the hospital for a 3-day hospital stay. If you have a Medicare Advantage plan, they can waive that. They provide nursing, skilled nursing, physical, speech, and occupational therapy, wound care. So you need a higher level of care. And these are the people, when you're looking like on the Housing and Home Care Directory, and it says they provide skilled care, that's Medicare, okay? They have to pay for care that is medically necessary. Usually you get 3 to 4 weeks under Part A, can be extended under Part B for outpatient care longer if it's medically necessary. These agencies are licensed by the health department as a Class A agency, and you again can look at their surveys with a link from our Housing and Home Care Locator. They are surveyed by the health department. Sometimes they're also surveyed by Medicare, and then Medicare will also assign a star rating, 1 to 5, and a 5 rating means that that is the highest rating that they can get from Medicare. So that brings our home care discussion today to a close. Next month, on April the 16th, will be National Healthcare Decisions Day. And so the topic that National Healthcare Decisions team is suggesting is, what are the keys to an empowered healthcare decision? So that is the topic that I will cover next month on April the 16th. If you pre-registered for the next session, which I had originally labeled or had identified as living with a dementia diagnosis, we'll do that one in May. And just a little bit about some of the services CGS provides, which I don't think I need to go through because the people I'm seeing on the call at this point in time are pretty familiar with who CGS is. Our Salute to Seniors this year will be on August the 22nd at Greek Events Center. And if any of you are interested in attending, we'd love to talk to you. If any of you are homeowners, I will bring to your attention very quickly that there is some discussion at the Colorado State Legislature about eliminating the senior homestead exemption. So if you are getting somewhere between $500 and $900 discount, if you will, or credit on your property taxes if you live in your own home, and you would like to engage with your state legislators about letting them know that that might be harmful to you, please put your name in the chat and I will be in touch with you. Additionally, we will be sending out information about that within the next couple of days. So that concludes my conversation for today. And so next I will try to look in the chat. And somebody put in the chat that if you have Kaiser, they will provide medical transport or transport to medical appointments. And that's from a health insurance perspective. That is absolutely true. Somebody else said with budgetary cutbacks, our custodial services in the home threaten to be limited and or discontinued altogether. I think we are okay on the side of older adults. We are not okay on the side of disabled individuals. And yes, there has been a lot in the media and there has been discussion at this stage of the game. And I expect there to be pretty significant cuts in home care services or custodial services for individuals who are qualifying based on disability rather than age. Could we see more cuts and more significant problems in 2027? Yes, that exists. And it is a real threat, in my opinion, that we will either have waiting lists or we will have limited hours of service or something. The next question is the legislation for property tax exemption is very important to me. Okay, Roxy, I will look on the registration and get your name. And Eric says, along with the senior homestead exemption, we no longer have the first $50,000 taken off our property tax assessment values. I am not familiar with that specific provision. Is that part of the tax bill that is winding its way through the legislature, or is that something else, Eric? If you want to come off mute and share, that would be great. Okay, the senior homestead exemption does allow that's the senior homestead exemption that basically provides the discount or the reduction, the credit in your property taxes. And that's $200,000. So I'm not sure what the difference of that is versus the $50,000 that Eric is referring to here. Are there any other questions? Okay, well, thank you all for attending, and we will talk to you soon. Have a great day. Take care. Bye.